Okay, thank you very much. So here we are on another webinar, uh, our monthly webinar from NSNU. And this time around, we have Dr. Gaurav Sharma, who is very young, but I believe very experienced in geriatric care. So all of us are on the call here, and I hope more can join in. Would be eager to listen to you, Doctor, on your expert advice on geriatric care. Uh,
Yeah.
what I normally do is to play a short video on NSNU, but I'll do that at the end. I will
Okay.
probably, yeah, I'll probably go this time around with you first. So please, if you could, introduce yourself. I mean, I can only say that you're from Hyderabad, you are a geriatric medicine expert, and you're with the hospital in Hyderabad, but I think you should probably let everybody know more about yourself and then go on to
Yes.
your talk, please.
Yes.
Over to you.
So we have our members from the Naya Savera Naya Umang, or we have senior citizens also here. I mean, it's more of a
Yeah, so
member
these
from
are
the NGOs. Yeah.
these are basically members from Naya Savera Nayu Umang, and
Yes.
it's a mix of elderly and
Right.
not so elderly. And
Right.
I mean, on the group, we also have a few doctors like you.
Yeah.
They may or may not
Right.
join, so we'll see. So that's the mix.
Right.
Yeah,
No problem.
over to
So
you.
to start with, I'll just stop the screen and I'll do again. So my name is Dr. Gaurav. I am right now based in Hyderabad. So I did my MD geriatric medicine from AIMS New Delhi. Post that I did my SRship in Banaras Hindu University, in that too in geriatric medicine itself. So per se, to first start with the concept of geriatric medicine itself, I think I should introduce a little bit about the subject. Considering Naya Savera Naya Umang already are dealing with the senior citizens, so the idea of geriatric medicine must already be there. But since it's still a new branch in India, it's almost been 10 to 15 years that it's been around. It was started in Chennai at first from Madras Medical College, and post that the AIMS New Delhi came up with it, and then now AIMS Rishikesh, BHU, and now with that 18 regional centers have this MD programs. So the whole purpose of the program is, in simple language, is just an MD pediatric for the younger, the children people, because definitely the physiology and all the changes comes while the patient grows old, while the resident grows old, the bone changes, the hair changes, the vision loss, hearing loss, and similarly the geriatric syndromes also come with it, like mobility issues and cognition issues and everything. So my profession is particularly dealing with the special geriatric age group and special geriatric problems with it. The dealing with the all the comorbidities along with the particular frailty, muscle loss, sarcopenia, and all with that. So we have very few of them in India right now. Even I feel all the states do not have a geriatrician. Even in Hyderabad, I think only one or two or three must be an actual qualified geriatrician who is an MD geriatrician. But yeah, we are growing in number, and this is vitally very important because the management is anyway different, depending seen by a physician and seen by a geriatrician. And that's why I was very excited to hear from Naya Savera Naya Umang, and I was very happy to accept the opportunity to tell about the subject and whatever share I can do about the care of a senior citizen. So I'll start. I'll just give me 1 minute. I'll Yeah, there was a little noise. So can I share the screen or
Yes, you can. I mean, if you want me to help on sharing the
yeah?
screen, I can also do whatever else.
No, I'll just see if it is visible for everyone. We'll just see it here. Is it visible?
Yes, it is. Yeah.
Yes,
Good.
yes. So I'll just brief a little bit about geriatric nutrition. And what the myths and realities of it, and how vitally essential it is for our general population. Now, so more often we see our patient, the older adults, coming up with having chewing problem, teeth problem, and they have this myth of diet restriction we should do if my patient. I'm a BP patient, I'm a heart patient, and some come with even taking the food. We have difficulty walking and all the mobility issues. And of course, the mood effect also comes in play when you talk about a geriatric patient. And I feel sad, I feel low appetite of it as well. So my presentation will be mostly dealing with the challenges what we have and whom should we assess and what nutrition we should do and the nutritional requirement and take home message. It's more of a technical slide. So wherever there is in doubt or any questions for a general sense also, then feel free to ask at the end. So often common myth we often feel ki someone's getting older, so they should eat very little, or we get ki the protein should not be taken too much because it's harmful with the kidneys. The milk and curd or some fruits causes cough or cold, and they often with these all causes they often tend to decrease the intake of the food. They often ignore the even vital nutrient protein for the development, and often they start losing muscle. That's anyway a physiological process. After 30-35 years, the decline of the muscle loss is anyway there. But whenever the 50 or 60 and the patient goes underway some catabolic state, or if undergoes a fall, or there's some other risk factors will be coming in the future slides, they have more decline of weight, which is actually very important and very difficult situation being a geriatrician than any other disease actually. So we all know there are different changes having in with the aging. There are physiological changes, there are biological changes, and there are socio-psychological changes. So these all changes, starting from the change in taste of the mouth, the decreased peristalsis, the decreased food pipe of mixing of the food in the mouth, and the locomotor function gets affected, in which the difficulty having mobility and difficulty cooking the food for themselves. Even cognition affects, so that helps them, that makes them difficult to even prepare food and all. So with all these changes, they are more susceptible to have dietary deficiencies. Their dietary intake also decreases, their absorption decreases, and their accumulation of waste products as well. So, what are the roles? So, this major determinant for active aging, it increases longevity in many ways if taken right. It is also a very vital. Nutrition is important to prevent chronic diseases. It provides immunity and provides good health. So they're difficult. Some have a more susceptible to have a bad nutrition, susceptible to have difficulty on taking food. So some have socioeconomic problems, swallowing difficulties, chewing problems, living alone, living in nursing home, chair bound, acute and chronic diseases. So as I mentioned earlier, this leads to the progress of malnutrition. This malnutrition causes the sudden muscle loss in the body. This muscle loss, along with the decrease in physical activity, causes something called sarcopenia, which is a different element, and it causes more vulnerability to have more diseases in the body. That is what we call as frailty. So that is being more increased in a patient, being more susceptible of having this diet issues. So there are different studies. They've already said that the dietary intake in geriatric populations is pretty much low, and as we said, it's mostly goes in a fashion of a vicious cycle. A patient even having a decreased limited mobility and independence, they tend to start having decreased access to food. Now this decreased access to food have decreased inadequate food choices. This have nutrient deficiencies, these have poor nutritional traces, and this again goes that the patient has an increased illness. This illness sometimes causes fall for a patient, and this fall again starts a different vicious loop. So it's very important to eradicate all the different steps and provide better nutrition, tackle the inadequate food choices, tackle the mobility issues and independence issues, tackle the cognition issues. So that's why seeing a older adult is more than a particular issue. Everything is related to all the entities, considering the chronic diseases, or considering the changes in the body, considering the socioeconomic changes, his even the cognition and everything. So everything has to be dealt at once when we talk about the nutrition. So, of course, there are different diseases having different complications, and that needs different attention in view of nutrition. So, whom do we screen? So, definitely, as I discussed in my previous slide, we should be more looking for someone is having more risk factors, considering someone is having dental issue, someone is living alone, or someone is having dealing with the dementia or mood disorders, or having a depression element in them. So that should be more taken care and more to be understood, that the patient or the particular older adult might have a high chance of rapid deterioration, or might have a this might need attention, that the nutrition element should be tackled. And therefore the different someone's taking more than five medication, which you call as polypharmacy, that also increases risk of having bitter taste in the mouth and not able to take the medicine, not able to take the food nicely. So that also increases the chance of having having malnutrition for the patient. Especially someone is recently hospitalized due to any stroke, or due to any fall, or due to anything, that also decreases the appetite of the particular adult, and that also increases the chance of malnutrition. There are different parameters which I'll not go in much detail, but to be very grossly, A, B, C, D, E is one of the very commonly done. Mostly we look for the dietary assessment. We ask for any last 6 months if the adult have any weight loss, or if he or she has been taking less. We also look for any dental changes or any pain that is preventing from that having it. With that, particularly typically a geriatric assessment is definitely should be done, where from tip of hair to tip of toe, as we say, some mobility to cognition, for sleep disorders, for urinary incontinence, everything should be looked for. And where someone nutrition is concerned, we should definitely look for the elements such as skin fold thickness, calf circumferences. There are different modalities. There are assessment tools. Most commonly used assessment tools is mini nutrition assessment tool. In a short OPD setup, MNASF is used, and that allows us to find out the risk factor the patient might be having a malnutrition. This malnutrition makes us more giving more attention that the patient might be having sarcopenia, and definitely after that, the particular treatment intervention needs to be done. So, as I said earlier, the subcutaneous fat stores for skin fold thickness, arm circumferences, waist circumferences, BMI, waist to hip ratio. And nowadays, body composition is a very good analysis, which helps us to understand the particular fat and particular muscle that the patient has. We do in our hospital, and we can be done by the bioelectrical impedance, but more accurate is the DEXA scan, which helps us to understand how much particular fat, particular muscle of the body, particular bone the patient has. So again, just a small slide on nasogastric tube. Sometimes the patient is already bedridden of what we see. If very old patient, but very old geriatric adult, which we address, that they have difficulty even taking food from themselves. So in that case, nasogastric feeding should also be considered. Considering he is not able to have any, he is living in very severe frailty. It is not a routine thing to do, but of course, if there's chances that he has much of difficulty taking food for himself independently, definitely nasogastric feeding is one way we can do. That also, a different macronutrient and base should be taken care of, and that the feed should be made in that way. What all different components, I'll be coming in the coming slides. So most important, my first slide, when we understand what the nutrition is, the protein intake, which unfortunately in our part of world is pretty much now ignored, and now it's coming into more attention that how important the protein intake is. Protein intake doesn't only help us to prevent the muscle loss, but it also helps in the repair of the body. It helps into the now helping with the cognition of the body. It helps with the mobility, and that per se prevent the chronic diseases, prevent the cognition decline. How much should be taken? There are different numbers, but typically 1 to 1.25 gram per kg per day is be taken. 1.5 gram per kg per day is taken unless the patient has an underlying renal or liver disease. Sometimes in severely ill patient or patient having severe infection, even 2 gram per kg per day can also be taken. So whoever is having even a slight, raised creatinine function or a kidney function derangement in patients says we cannot take protein or we should not take protein, that has avoided, that is morely worsening the nutrition part. So that's a total myth. The protein should be taken unless contraindicated. Good quality protein. The intake should start itself from the normal diet of the patient. The starting from the everyday whatever he or she is taking, and some vegetarian diet includes paneer, tofu, broccoli, and non-vegetarian includes eggs, lean mass. Yeah. So that is the this. Another is carbohydrate intake. It's said to be 50 to 70% of total energy requirement. But however, now the very recent the American pyramid food pyramid they had made is they have kept in very low intake of carbohydrate intake. In fact, it's now said to be just 20 to 30% that should be taken, and more emphasis on protein, more emphasis on fibers, more emphasis on fruits and hydration that has been increased. Similarly, fat intake, there's a myth that we should not take fat at all. A good fat, fat with a poly unsaturated fatty acids should be morely taken. One of the examples such as omega 3, omega 6 fatty acids should be taken. It not only helps us to improve the cholesterol in the body, it also helps us to improve the cognition and decreases the chance of the cardiovascular disease. So omega 3 fatty acid and fat intake should also be taken into picture. Definitely, that's why the Mediterranean style of food now, which has olive oil, tree nuts, peanuts, fatty fish, seafood, white meat, this has been now coming up more importantly. This was in the picture for cardiovascular health. Now it's more importantly seen for a longevity and for the cognition improvement of any older adult. Fiber intake is also important. Fiber intake helps for the improved gastrointestinal symptoms, improves for the constipation, and this reducing in constipation itself helps in the feeling better for the patient, and it improves the gastrointestinal overall health. So, in short, the whole dietary intake is morely emphasis of the three or four important elements, with more of micronutrients to be assessed. Definitely, if the patient have a risk of malnutrition, these are the ways we can do it in the hospital setting. The different micronutrient that has to be taken care with the food is vitamin A, vitamin D, vitamin E, K, and all. And sometimes the deficiencies of this, for example, vitamin B12 deficiency causes the peripheral neuropathy, which is called as a tingling sensation happening, or the numbness in the body. The iron deficiency causes something called restless leg syndrome, which causes acute cramp and pain in the body. Sometimes magnesium deficiency causes more of the cramps and the sleep disorders, so that also needs to be seen. Vitamin D deficiency causes more of fatigue, more of the bone, bad bone health. So vitamin D should also be taken as a supplement as well. So there are different diets which I'll not go much in detail, because if there's a weight reduction, the more emphasis should be taken for cereal, oats, fruits, vegetables, pulses, meat and poultry, oils, and less. Always the less should be fried and sweetened foods, high carbohydrates, carbonated foods. These all should be always be should be avoided. Similarly, for diabetic diet, also whole cereal, pulse, oats, fruits, vegetables, and less of maida, less of high fat food, fried and empty calorie food should be avoided. So different things which you should avoid or not. I'll kept it short, but the more take home message from my side is protein is your friend, and weight loss is not normal, and you should be more hydrated. Even though you have the urinary incontinence, that should be addressed. There are different ways to address urinary incontinence too. Try to avoid taking too much of water after 7 8 p.m., 1 hour before sleep. But overall, for the muscle health, for brain health, the hydration is very important. Aging is not starvation. Aging is not weight loss, muscle loss, falls. Those are not aging. healthy aging or healthy longevity starts from the age of 40, 50 years, where the improvement of all the general of sleep, diet, exercise to be very majorly seen, and having regular checkups done, and eliminating the risk factors and eliminating the nutrient deficiency, one can attain a very good health. And that's my slide for nutrition. I'll just try to keep it short. I'll be happy to take questions if there is any.
Thank you very much, Dr. Gaurav. I think that was very, very educative in a short period of time. Uh, I mean, you mentioned about a disease. I think I caught the name not very correctly.
Sarcopenia? Yeah.
Sarcopenia. Do you want
Yes,
to
yes,
elaborate a little bit on that disease? And
yes,
of course, you mentioned about precautions that one should take, but God forbid if
yes,
one is inflicted by that disease, then what
yes.
is the cure?
Yes. So sarcopenia is rather what we can say is one of the kind of an accelerated aging, if you say. So there are two main entities when we as a geriatrician see for any elderly coming after 70 years or even earlier in the life. So sarcopenia is, in simple terms, caused as sarco means your flesh, and penia means decreased. So when the muscle from the body is decreased, which is ill proportional to the age that person should. There are different markers which try to see of how much muscle loss someone is having. So that is one way we grossly can say is sarcopenia. There are definitely some of the criterias, some of the screening tools such as SARC-F, and after that the confirmatory diagnosis. We have different tools to see that. But in general terms, a general an older adult having a decreased muscle loss, a decreased muscle or a muscle loss, is termed as sarcopenia. This is associated with his decreased functionality of his day-to-day lives. Now, this decreased muscle can make him difficult to do his general work such as bathing, cooking, such as going to washroom, transferring, and everything. So that is in pure terms called as sarcopenia. This is closely associated with something what we call as frailty. So frailty is an entity that we should use of someone defining of how much vulnerable he is to a particular disease or particular any insult in the body. So a 70-year-old or an 80-year-old having a very fit life, having very good muscle, having taken care of himself, can be, not can be non-frail and can be having a very good of his physiological aging he must be having. But someone even 60 years of age having more many risk factors, and not being very healthy with the preventive things they do, then they can mostly have this accelerated aging, as we call as frailty. But in very particularly, the muscle loss is what we call as sarcopenia. How can we prevent it? So very importantly, definitely number one thing we should do is take care of our diet. And whatever diet or someone is having a decreased intake, or having low appetite for any reason, that should be addressed, number one. Number two, the chronic diseases of the patient, of the particular person, should be managed. The inappropriate multiple medication should be avoided, and just adequate medication should be done. And number fourth, which is top of my chart, top of my pyramid, is strength training. So we still in our this Asian population have not so sensitized about strength training. That is basically weight lifting for our upper limbs and for our lower limbs, such that we preserve our muscle and we do not lose them further. And to screen for nutrient deficiencies such as vitamin D, such as calcium, such as vitamin B12, and enhance the nutrients in the body. And definitely we can prevent sarcopenia.
Awesome. I think those are great tips. You said that I mean, in your profession, there are not too many available, at
Yes, yes,
this point in time. It is still a
yes,
new profession, 10 to 15 years still new. Now, for somebody who has to consult a geriatric expert like yourself, doctor, what would be the way to go about? I mean, one straight question would be that for those who are living outside of Hyderabad, would you be in a position to share your number and would you be available for online consultation? That's one straight question, I think, for me and so many others would be interested in knowing that
Yes.
is online consultation helpful or is it important to club that with physical, yeah, physical checkups? I mean, how does one go about,
Yeah.
basically taking care of muscle loss, frailty? I think
Yes.
those are things
Yes.
which even the younger ones don't pay so much attention. The ones who are in their
Yes.
60s, and then as you go to 70s and 80s, it appears as if, most 70s and 80s, as the muscle loss happens, they think it's normal. Diet loss is normal. I mean, it's not something that we should be bothered about. Maybe today's, your talk will bring in that difference. But what would, how does one sort of take care of that?
Yes. So I think now we are improving in that direction, and now pretty much many longevity and geriatric expert are coming over, and they are being very sensitized about the idea of this aging and this accelerated aging. So in our at least what I would say, if not very young, but at least 40 to 50 years, the midlife is a very good age to look upon yourself now. If you not have done in before of your age, the 40 years or 45 years is the best time to see, used to keep looking at your general checkups to see if what parameters or what body you've been lacking. So this general checkups not only helps us to just do the test and find the deficiencies, but it also motivates us to improve that further. That is one. And again, the concept of muscle training, and again coming back to the basic: sleep, diet, exercise should be very basic, and one should be trying to be more educated, which I often tell to my patients and their attenders as well. That the sleep should be given top priority, the diet should be given top priority, and exercise should be given top priority. Diet should be minimize the ultra processed food, minimize the sugary food, minimize the oily food, and increase more of the protein rich food. And exercise, when we say exercise, the mix of exercises, the recent study also even came that mix of exercises of having the aerobic and having aerobic exercises in form of jogging, walking every day at least 30 minutes, and having at least three times strength training. And now that includes three body part, you can say upper limb, lower limb, and the core of this. So lifting and having good variations of 4 5 exercises at least 3 to 4 times a week. And starting a habit of that from 40 years, 50 years helps us to maintain that normal aging. And yes, I mean, we are still now struggling with many communicable diseases, and now the concept of having preventive diseases, of prevention, is now coming up. So that is one. Talking about the next question of how can we see a geriatrician, how can you see me if at all? So first of all, if anyone having nearby geriatrician, having a physical geriatrician, now we have 18 regional center, and I'll be happy to help with anyone nearby having that, of any state rather, that will you can see that that is the best thing to do. If at all you need my expertise, we have service of teleconsultation in where I work, AAG Hospital. So I will share you the link. I'll share the link to you, and we can have a portal through that, and we can definitely see in a teleconsultation. So yeah, so just my take home will be, just familiarize yourself with what a geriatrician is about, and he or she doesn't only take care of your diseases, chronic diseases, but also goes a step further to see for your brain health, to see for your muscle health, to see for your sleep health, to see for your mobility, and that is as equal as important to see of taking care of the diseases. Yeah.
Thanks, Dr. Gaurav. Manu, you have a comment or a question? Maybe you want
Yeah.
to unmute yourself and
Yeah.
ask.
Yeah. I think she's much needed. I have to leave it. She's there.
Manu, oh, he's probably left.
Yeah. So
Okay.
for her
Yes.
question, yeah, yeah.
Yeah. No, go ahead, please. On the comment of the chat.
Consuming protein 1.25 times of body weight is tough and sustained basis. Are there protein supplement powder should we use? So what I usually generally say is 1.25 is, you don't have to straight away jump into 1.25. Even 1 gram per kg per body weight is enough. Now, the Indian plate system of it, we have of more of rice and more of sweet one dessert in the picture. And so more of carbs, what we are having. So first of all, we should fix our diet, the three times diet what we are having. We can start off morning with good amount of nuts, good amount of seeds, good amount of walnuts and everything, good soaked. We can start off with that. We can replace the morning with at least oats. We can do that in the daytime. Less of a rice, more of incorporating, if a vegetarian, then soya bean, paneer, tofu, broccoli. Once and all in diet. And if you're a vegetarian, or if you're a non-vegetarian, so at least 2 eggs per day, definitely. And adding a bit of lean chicken or something, at least twice or thrice in a week. And by the end of the day, just not eating anything after 7 or 8 p.m. and finishing a diet by that helps in sleep also, and not eating anything too heavy. And so that is a general way of first changing the self diet, and that we should not jump into the protein supplement altogether. And finding different forms of protein, yogurt, incorporating in our diet, legumes, chana, badam. So these all helps in the increase in the protein intake anyway. Now, even apart from all this, now if there is a deficiency, and when we see there's just let's say 50 or 60 gram of protein we are taking in a day, then to finish that 20 gram of protein, we may use a protein supplement. But again, protein supplement, one, it should be authentic, it should not be adulterated. Two, the kidney function should not be very bad. By very bad, I mean bad. It's not key. A little bit of increase of creatinine should not eliminate from you not taking the protein. And number three, the intake should be regulated. Like you should start with 1 scoop, then 2 scoop. That's what I want to go with things, because that helps to prevent any bloating or gastritis issue. And suddenly once start having it, and they start having these gastric symptoms, and they stop themselves from having any further. So that's why I usually tell them to go slow, go low, go slow, and try to more change of the daily diet itself. That's more important.
Thank you, Dr. Gaurav. Uh, does anybody else have any questions or comments for Dr. Gaurav? Please feel free to unmute yourself and ask. Okay. Seems like there's no immediate question. But like you
Sure,
said, Dr. Gaurav, it would be nice if you can share the link.
sure,
So if anybody wants to reach out to you for consultation, they can do that.
sure, sure,
What I'll do now is I'll just end with a short video on NSNU. This is
sure,
just to sort of yeah, inform you as well as others who've been on this webinar for the first time in terms of what we are doing. But primarily, we work with the elderly in three verticals. So one is the elderly in the old age homes in cities, then the elderly in the urban centers in general, and the other that we are beginning to look at is the elderly in rural households. So at the moment, we are restricted to Delhi and Lucknow within India. We have plans in place to start Pune, Jaipur, and Kolkata in the course of this year. And over time, of course, we want to expand our footprint to several more cities, primarily in India, but a few even abroad as well. I mean, what we've looked at is that the issues of the elderly are common, and from our own research and our own brainstorming within the governing body and the other chapter committee members, we felt that primarily the elderly have four pain points. One is around health issues, and this talk around geriatric, of course, relates to that. The other is, of course, around inflation and cost fighting as a steady source of income stops. The third and the fourth are kind of interrelated in the sense that loneliness is, I think, one of the big things, which is also related in a way, leading to physical and mental illness. And the fourth and the last is, of course, the issue around being dependent for small things on others as one ages. So I'll just share a short video, and thereafter, I think then we'll do the honors of closing out.
नया सवेरा नई उमंग. Beyond years, beyond boundaries. A new dawn, a new hope for our seniors and for all of us. The story of NSNU began with an idea, a thought, shared in conversations among friends, classmates, and like-minded professionals. The idea was simple, yet powerful. Our seniors, with their vast wisdom and life experience, deserve not retirement, but renewed purpose and engagement. When this thought was voiced, it struck a chord. One by one, friends, batchmates, and colleagues came forward, inspired to join hands. Together, they transformed an idea into a movement. And thus was born Naya Savera Nai Umang, a collective effort to bring dignity, connection, and joy to the lives of seniors and elders. India's elderly population is rising rapidly. By 2031, seniors will make up over 42% of our 1.45 billion people. Yet, their wisdom often goes unused. Many face loneliness, poor healthcare access, financial dependency, and inflationary pressures. This is the challenge NSNU has set out to address. NSNU works through 5 core focus pillars: health and well-being, affordable healthcare, yoga, naturopathy, health experts, community engagement, social activities, immersive experiences, knowledge sharing, estate and financial planning, legal, financial, and estate guidance, advocacy and awareness, policy engagement, government benefits, senior citizens' rights, collaborations and support, volunteerism, donations, awareness campaigns, and collective action to create lasting change. From regular city events and national level conferences to family gatherings, advisory opportunities, and discounted skill development programs, NSNU offers seniors opportunities to connect, learn, and contribute. We bridge generations, allowing young professionals to learn from the wisdom of seniors. At the heart of NSNU is a powerful, skilled, and mission-oriented team. Seasoned professionals with more than 3 decades of experience each, working like a well-oiled engine to drive our vision forward. Sami brings international corporate and development sector expertise. Sanjay adds deep knowledge from business, IT, and legal consulting. Surendra contributes his rich industry experience. Manoj carries with him discipline and leadership from his distinguished service in the Indian Air Force. Ravi strengthens the team with corporate and business insights. Suranjan adds professional depth from the development sector. And Balvinder complements with extensive corporate experience. Together, this leadership team provides the drive and direction needed for the ambitious mission and vision of Naya Savera Nai Umang. By 2030, NSNU aims to reach 100,000 members across 50 cities with 50% women participants, supported by 25 strong partnerships. Our mission is simple: to ensure seniors live not just longer, but better. At Naya Savera Nai Umang, we believe aging is not about slowing down. It's about living with renewed purpose. Join us as members, volunteers and supporters. Together, let's give our seniors the dignity, engagement and joy they deserve.
Thank you very much for patiently listening into that video. We'll end it here, but Dr. Gaurav, many thanks for
Thank
taking
you.
time today to speak to our audience. We will put this recording on the NSNU YouTube channel and then share it with the 350 odd members that we have on the group. The idea is basically to continue with the series over February and March, and then in Lucknow and Delhi, where we are present, we are looking at doing in-person deliberations in one of the hospitals in Delhi NCR and in one of the hospitals in Lucknow. So hopefully we can invite you to join in person if possible into those events. But we will definitely stay in touch. And please share your details, your link on the chat
Sure.
with me so that I can share it further on. But thank you very much for your time.
Thank you. Thank you for the opportunity. Thank you.
Thanks everybody for joining in today. Cheers. Bye. We'll stop the recording.